So thank you for joining us. Really appreciate your time. As you can tell, I'm a Brummie, but I actually work in Derbyshire. So my name's Hayley Grice, and I'm a physiotherapist by background. But I've now in an improvement lead post jointly with Amanda Kerry, who's going to come in as well. So we are a Derbyshire community team, community trust, and we are the improvement, innovation, and effectiveness team. We're going to talk you through a bit of our journey, and a bit like True QI, it is a journey. We're not at a final destination. We're very much feel like we're always learning, we're always improving. So we're not offering you this is a package that's a done deal and we've got this perfect. We just want to share our story and see if any of this resonates with you, and if there's anything we can learn from you or anything you can take away from us. So I'm a physio by background. I've also got some research qualifications, but very much have come into an improvement team, and really enjoying the QI networking and the QI community. I'll let Amanda introduce herself.
Thanks, Hayley. So hello, everybody. My name's Amanda Kerry. I'm a non-clinical background, and I've been working in private sector and charity sector, mental health and elective surgery since 2014 in quality, compliance and risk positions. So I've done a lot of sort of QI teaching and working with clinical colleagues, but more from a hands-on as a result of the clinical audit and the CQC requirements, the sort of the registration side of things. So I've only been with DCHS for coming up 2 years now. Wow, where's that gone? But it's a really good team to work with. We've got some great people within the trust, and we're on that journey, like Hayley's just been saying. There's definitely a desire for QI, but there's also some what is QI and how does that fit into what we've been doing. So we'll talk you through that a little bit more in the presentation. I'm going to hand you over to Lauren now, who's also going to present with Hayley and myself.
Hi everyone, so I'm Lauren Gascoigne. So my background is non-clinical as well, but I started off in the NHS about 5 years ago when I worked as a clerical officer at Sherwood Forest Hospital. So I was on reception in one of the clinics, and that is an acute trust as well. And then after a few years there, I secured a role in this team 3 years ago. So I moved over to the community trust as an assistant within the team. And then in October of last year, I secured the role for a secondment within this team still as a communication engagement and project officer. So still been within the QI for about 3 years, still learning every day, but absolutely loving it. I'll hand back over to Mand.
Thanks, Lauren. So we thought we'd give you a little bit of an introduction into our team. We've got Sarah and Lisa, who are our senior leadership, and they're both from clinical backgrounds. Lisa's actually on the call today. So Sarah's a matron by background, and Lisa's a physio by background. And then within the team, we've got a further 2 physios in the team and a midwife as well. But then amongst the rest of us who are non-clinical, we've got a teacher, we've got admin, we've got IFM, so estates facilities, we've got analysts, we've got sort of sequin, audit sort of background in there as well. So like I say, we've got quite a diverse team. Of the team that we've got there, 12 of us have completed the QSA-P training and 5 of us have completed QSA-A training, and we'll explain a bit more about that. And that's something that DCHS have supported us with as a team for that training. There's also 7 of the team who've completed training with clinical audit support services. So I don't know whether that's a team that you're familiar with, CASC. So we did clinical audit and we did train the trainer training with them as well. And we actually achieved accreditation with those. So 2 of our team, you can see there, have got the Lean Six Sigma qualification, and that's probably not used so much in healthcare, but more from sort of industry and manufacturing. But again, it's got a very QI focus, so we're pulling from that experience. And then one of our team is actually currently on a secondment to Chesterfield Royal Hospital, which is one of our local acute hospitals, and she's working in the Royal Academy of Improvement. So we're pulling and understanding some of the transferable knowledge and skills from what's happening at our local acute trust into what's happening at the DCHS as well. So we just wanted to share as well some feedback that we'd had. So we had what we call our insight visit, which is our exec team coming to just do a touch base visit with our team. And neither Hayley or I were actually present at the day due to other commitments, but the feedback that we actually received from our chief nurse, and we're both very proud of this, and I know Lisa is as well, was that we are a cohesive team who have made the transition from focusing on clinical audit activity alone to embracing and driving the quality improvement agenda across the organisation. We have a desire to empower colleagues for the benefit of patients to get to a position where staff are being supported rather than having to be invited. So we're very proud of the skills and the expertise and the drive that we have. So we just thought it would a good opportunity to share that feedback with you. So that's the reputation we're trying to get across our trust. So I think I'm handing over to Hayley now.
Thanks, Mand. And I'm just talking about the team itself. We have had quite a lot of personnel changes. And what we really say is actually within QI, that fresh pair of eyes, and actually sometimes personnel changes, we're really trying to do that QI in QI. So that's probably a bit about, again, our kind of structure as a team. We're just sharing here a bit of a timeline, just to give you a bit of context about our journey as such. So we've actually come from an audit team. So we were a clinical effectiveness team with a portfolio of clinical audit, sequins, NICE guidance. And actually at that point, quality improvement and QI sat more with the transformation team. But then in about 2021, we then got quality improvement come into the portfolio of the improvement, innovation, and effectiveness team that we then were kind of renamed. So we actually added QI to our portfolio. So we do QI, but we still do audit, sequins, so more of your mandatory assurance, and looking at NICE guidelines as well. So we've just tried to pick out a few kind of key highlights from our journey, really. And I think what Man's already touched upon is actually we've done quite a lot of investment in training of the team. So we've invested in, let's get those within the improvement team as such, all talking the same language, all having that same kind of basis. So that's the immediate improvement team. And then we've also looked at how we can network. So we've networked in terms of establishing that our QI faculty, actually, they didn't want to be called the QI faculty. They rebranded through co-production to become the QI community. We've also started reaching out more externally. So we've done the NQI Comms network meeting. And again, we're starting to do more within our system as well, which is Joined Up Care Derbyshire. So we're just going to go through the next few slides, just kind of touching on a bit more of detail about some of those key markers in our timeline. But if you've got any questions afterwards, please come back to us. So I mentioned the QI faculty. So the QI faculty was actually set up by the transformation team within DCHS, but with investment from the research teams and investment from executives that had a bias towards quality improvement. And what was really established early on within DCHS is that people do want to make work better. People are invested in service improvement and quality improvement. And what the faculty did back kind of in 2018 is establish that QI is for everyone. So that's the basis that was already in the trust before it then came into the portfolio of the improvement team. And again, there was a realization that the improvement team themselves, we can't hold quality improvement. Actually, we need the enthusiasm and the commitment and actually the drive from staff all across our community trust. You know, that's, you need power through numbers and through networking to really drive forward quality improvement. So that was already in the culture before then the quality improvement came under our improvement team. Amanda will talk you through a really significant part of our journey, which was establishing our QI principles.
Thanks, Hayley. So what you can see now in front of you are the DCHS QI principles, and in fairness, Lauren, Hayley and myself can't claim any credit for what I'm about to tell you because it all happened before we were in the team. So Lisa should be very proud of this, because this is what was done before we joined the team. And in fairness, I have taken this feedback from Lisa. So I asked Lisa, where did we start? How did we get these QI principles? So around March 21, a scoping tool was used, and we actually reached out and achieved 100 voices from within the trust to think about and learn about what QI already existed in the trust. And Lisa was very passionate about not introducing this as something new, but something that already existed that we could enhance and grow. So we had engagement examples from different individuals, different teams, different forums, governance groups. So meeting across all the sort of levels and tiers across the trust. And Lisa was very focused on, and I'm actually going to use Lisa's words if that's okay. She wanted to everywhere and anywhere to talk QI, most importantly, listening to people more than speaking. So understanding what was already in that culture and listening to those voices. So out of that piece of work, they became some strong themes. So there was some analysis, and I know some QI tools were used. So for those of you who are used to some of the QI tools, a driver diagram to focus, and we could have shared it with you today, but it felt a little bit oversharing. But out of that, we came up with these 8 QI principles. So dropping the jargon, using language that people understand, having it at the heart of what we do. So we're true to it every day in what we're doing, being able to share, and that's sharing. I'm going to lead into something else, the good and the bad. So safe to fail. So where something's gone wrong, let's share and learn from that. Reducing the red tape, take that bureaucracy out of it. And this is what DCHS staff were saying in those engagement sessions. Giving people permission. It's almost like they felt that they needed to be told they could do it. But why? Why have we not created that culture where people have done it? I've already mentioned the safe to fail. Staff led, they're the people who've got the ideas. Let's enhance those ideas, and let's make it easy as well. Let's make it straightforward, and that then removes some of those barriers. So I've summarised this really and thought, because I've come into this when these principles are actually in place, I can see this. And like I said, I've been with the trust now coming up 2 years. I see these words used, that they are words that we are, and language that we're using. I see this poster out and about in the trust. I hear people use them. They if somebody's got a presentation, they're familiar with them. So these principles in today in DCHS, they're familiar, they're used regular, and they're used throughout the trust. And we're embracing them in our QI community forum. So we have I think it's once a quarter, we use a QI community forum, and we've got QI community members who are out in the trust working every day in their normal day-to-day jobs, who can spare an hour and a half every quarter to come along and learn about what QI means, and they're using this language. So it's those ripple effects, and you can feel it rippling out through the trust. So I think I'm adding back to Hayley now.
Thanks, Mand. So we mentioned on our timeline that there was a QI faculty, and then actually we did some co-production and we renamed it QI Community. But actually, some of the principles that we had in our QI faculty, the name was important to change because I think it established more of a safe space forum. It opened it up to that non-hierarchy, that actually our QI community is for everyone, all levels. And actually, as a team, we're really holding ourselves to account to that. We've got a kind of key performance indicator, a KPI, but actually we don't want to keep meeting the same people in our QI community that we meet in other meetings. We want actually some more lower band staff, some of our non-clinical staff. We're trying to get admin into that QI community. And we're really trying to get a spread so that we do feel that actually we're getting a representation, and we're getting a bit of a challenge because QI is established in some open doors and some really engaged people, but actually we really want it to spread throughout the organisation. So it is part of that, the heart of what we do, and there is a culture piece around it. But I was looking back on the QI faculty kind of communications that came out back in 2018, because I am one of those people that keeps emails because I knew it would be useful. And actually what we established when it was the faculty is some of the things that we're staying true to now as a community. So actually we realised that our capacity and capability for QI in DCHS was through networks. It wasn't just the improvement team or whatever that team was called. It was actually about having members, mentors, coaches across the trust. It was about having a method so people knew there was some kind of process and methodology to where you take an idea. There was already talk about, even before we did our CUSA training, about having tools, about looking at process maps, about really having quality conversations. So there's that balance between doing what strategically is needing to happen within QI, but also knowing that a conversation with one person can actually lead to a really impactful project. We realized that actually we needed a website. Some staff are in the community, they're busy, they might not be able to come to live events, virtual events. They needed somewhere to go to find all this information when they had the time. They wanted a library so that they could look at past ideas, past projects. And we highlighted on our timeline that actually in 2019, during a pandemic, we procured AMAT. And that was about having a platform where actually there was a library so that people could look at what has previously been done, get ideas, think about how you could turn audit into QI. So there's themes that have come through, whatever name or whatever team is driving QI, that we're still using within our QI community. There was also a sense of identity, and Lauren's going to tell you a little bit about how our QI community has grown and what their feedback has done to kind of develop that.
Thank you, Hayley. So, like Hayley said, so they sent out a survey. I think it was to 67 responses that they received, just to sort of find out what people are actually wanting. So, you can see on the graph there that they wanted to change the name from QI faculty to QI community. So that's what we did. We also asked how often they want to meet. So obviously we didn't want to be, they've got their own pressures and stuff, they can't be meeting every week, so we decided on quarterly. And that sort of works for us as well, so we can get a lot of information in the meantime, and we've got stuff to share with them, and they're still really engaged. We're not leaving it like 6 months, etc. And we also asked how long they wanted the sessions to be. So they went for 90 minutes. So within that, we have all the sessions that were on 90 minutes, and we don't have a break within that, but we have found that they still stay really engaged. And we can fit a lot more in. So we usually have, we do a bit of an update from what we've been up to. We sometimes have 2 or 3 speakers from throughout the trust who've done projects, sharing their projects. And we also sometimes do some polls to sort of engage people, see what they've been up to as well. We also asked when they wanted to meet. So on this original survey, they said morning. However, we did find that when we were running them in the morning, we're getting predominantly like managerial level service leads, which is really great, and that's what we want. But we also wanted, like Hayley said, to engage those people on the ground, people who are running clinics at that time. So when would be best to run the sessions for them? So the last one we did last week, we did that at 12:30 till 2 over lunchtime, and we got 53 people on the call for that, and that was really great. So we found that over lunchtime is sort of that best time for us. So we are running the next one over lunchtime as well. We have had good responses saying they're going to attend already, but we are aware that we will sort of fluctuate with what the staff need. If it goes back to the wanting it in the morning, in the afternoon, which days we're doing, we're going to stay really flexible so that we can stay as accessible to as many people as possible. And I just want to say, so our QI community membership at the minute is actually 226 members throughout the trust, which we're sort of really, really proud of. And we are getting people email at least once, if not twice a week, to join every week. And we're getting them from all sorts of different places throughout the trust. So yeah, we're really, really proud of our community.
And we're actually interacting with them, aren't we, Lauren, kind of outside of the meetings now? So we've got an MS Teams channel, and we're starting to give more of a flow of information in between meetings as well. So again, there's a bit of an ask of actually not just being present in the meeting, but what they can do, you know, daily.
Thanks, Hayley and Lauren. So I'm going to talk you through a QSA. I think we've all used it in this presentation. So QSA is Quality Service Improvement and Redesign tool, and it was actually created back in the NHS improvement days, and it's now part of the NHS England recommended toolkit for quality improvement. So all the team actually attended this, and so our senior leadership, Sarah and Lisa, and all the way through our band 6s, band 3s, band 5s. So the entire team went through that QSA practitioner qualification. Well, it's actually an accreditation. No, sorry, this is actually an attendance to understand the tools, and we did that from February 22 to June 22. So that's actually, it was a 6-day commitment where we went to, I'm going to call them workshops, and they were run by our local acute trust, and it was running through all the different aspects of QI tools. Once you've completed that, you can then go on to work towards a QSA associate. And I'm pleased to say there was 7 of us from the team who worked at that. So we were invited to join in July 22, and we all did presentations and our accreditation back in October 22. And I'm really pleased to say that we all achieved that accreditation. Hard work, but really achieved. So I'm just going to tell you a little bit about achieving that QSA accreditation. So it's a micro-teach session on part of the modules, and for myself, I did a measurement for improvement module. I then also had to present a scenario, and the details of the scenario are there, which I won't explain. I believe you get a copy of this presentation, so you can actually look at that. But it's a scenario in thinking of a certain circumstance where you may be asked to support a team within your organisation with a particular problem, and then you have to present a 10-minute presentation on what you would do in a 90-minute meeting. So I've included some of the tools that I presented on there, and it was a really good experience to revisit the QSA practitioner tools that you'd gone through. So you've been on a workshop, you've thought about how you would use a tool, you've gone away, but we've all done it. You go to these courses and you've got great ideas whilst you're there, but then you get back to your day-to-day and you think, oh, you forgot about it until you need to use it. So it's a really good refresher to bring those tools back in. And I'm hoping that the next part of this slide will show you the tools that I have used since I've been I've achieved the QSA associate. So some of the tools that I've been using is a sustainability model, and that was a really powerful model that I used for somebody who was running a project that was reporting into our SEG. Process mapping, that's been quite popular for us as a trust. I think we've had about 5 different process mapping sessions. I've only been involved in, I think, 2 or 3 of those. SPC and run charts have been something I have used a lot of, and a little bit further in the presentation I'll explain about how we're trying to look at our clinical audit activity through that QI's lens. Brainstorming, we've used that ourselves in a team. We do tend to default to that if we've got ideas or we can see a problem. We also, let's get the brainstorming tool out. Driver diagrams and affinity diagrams, we love one of those in the team as well. So any challenges that we've got, we default into those as well. So they're just some of the examples. And then I've actually given you there my top takeaways from QSA. So for me, it was about making data useful for improvement. So from my experience, clinical colleagues understand the problems, but when you can use that data to be meaningful and start looking at what's causing the problems, it becomes very powerful. Having the right people involved and engaged through the project and at the start of the project, and then agreeing roles and responsibilities. And there's some of the challenges that we faced, and it feels that the QSA tools have almost, they're working and giving us permission to address these issues that we're finding in some of the projects, or where some of our projects aren't as effective as they could be. So that's just a taste of QSA. So if we move on to the next slide, I think you've got me again. I'm going to talk about the QI definition. So we've taken inspiration for our QI definition from the Health Foundation, which is to work on systematic approaches to improve the safety and experiences and effectiveness of care. So that's about the patient and staff for us at DCHS. So we should now be able to see DCHS as definition. So quality improvement is about people closest to the problem being able to think differently, to explore creative ideas, and by giving them the permission, time, skills and network and resources they need to pause, think and test out to make their ideas happen. And then that the little logo at the bottom is something that we've created as a team that we use throughout, and it's just that think differently and then feel that difference that you've made. So at this point, I'm just going to pause, because when we've been preparing this presentation, that's exactly what all 3 of us have done. And we've thought about, so what does QI, what does it actually mean to us? So whenever we're in a work situation, and I'm probably going to use an example that we've had recently, we're working on a particular project, and Hayley, Lauren and I are all involved in this. It's actually a request from our assistant director, and we're working, it's actually called We Care. So we're looking at how our services and divisions can actually self-assess and just get a picture and a feel for where their services are and where their teams are. So we're engaging with the divisions within the organisation, and there's been a little bit of a as projects do tend to, a bit of a fatigue. We're not quite sure where we're going, we're not quite sure where we've been, how have we got where we've got to. So it's allowed us to take a bit of a pause, and what we've done is we've taken it back to this QI definition and those 8 QI principles, using those QSA tools about what are we actually trying to do. And if we've started out with an aim at the beginning of the project and that's not leading us where we want to be, there's nothing wrong with actually taking a few steps back and then taking it in a different direction. And it's about having that permission that if you've got something wrong or it's not gone where you think it should be, it is safe to come back and pull something back in. That's safe to fail. Have we got that thinking time? And all of us are really busy, the clinical pressures that our colleagues have, but that realistic, how do we achieve what we're trying to achieve within that time? Because if we keep stalling, we're never going to get the achievement, we're never going to deliver on the project requirement. But at times it is the right thing to take a pause and take that step back. So have we got the right people, that network? So do that engagement. Think about who your stakeholders are. Keep looking back at that stakeholder engagement and that stakeholder analysis, because you might come along to so far through the process and realise that you've missed somebody at the beginning, and that's absolutely what happened last week in one of our meetings. We were thinking about commissioners for the trust, but some of our services have specific commissioners with specific requirements for, say, children's services, and that's something that we'd miss. But again, that's okay. But so keep reassessing these, and if you use these definitions, you use your QI principles and you stay true to them, and check one another, challenge one another, take it back, it just gives you that pause and that reapproach. Hayley, is there anything, can I bring you in and think, is there anything that you wanted to say on this bit?
Yeah, I think for us, QI is a concept. People talk about it a lot, but I think it was really important that we actually nailed a definition, and a definition that reflected that our approach to QI is very much, if staff are happy and have joy in work, they will deliver better care. And I think that's where, it is a slightly more touchy-feely definition that you might see in your health foundation, but actually that reflects how we are approaching QI. And certainly, I've got that empathy as a clinician, that I always had the drive and I wanted to do this in my day job. But sometimes you need something that gives you that permission to go, actually, I'm going to stop off the hamster wheel, and actually I'm going to really focus on something I'm passionate about, that and that I think needs to change. And hopefully, by staff knowing our principles and knowing our definition reflects those principles, gives them a bit more strength to actually, say to their line manager, or give themselves the permission to pause and actually go, no, we need to do something about this. So I'm really passionate that hopefully this connects with clinicians. So it's that how you connect quality improvement from a quality division team that are sitting slightly separately to clinicians, right down to actually the end of the day, we're all here in the NHS to deliver patient care.
Thanks, Hayley. So now we've talked a bit about our training and our background. Our next slide is going to showcase some of what we're proud of. And what we've actually done here is each one of us have chosen one of these particular proud moments to just go into a little bit more detail. So you've got me again for the next slide. So I'm proud of how clinical audit can turn into a QI project. So the next slide that we've got, would you mind moving on, Lauren, is about clinical effectiveness turning into QI. So please don't be put off by the volume of information that's on here. I think the important thing is the graphs on the right hand side. So just for clarification, the detail on the left hand side you'll be able to look through once you receive the slide deck. But this is some work that we've been doing on our sequins. So we have a nutrition sequin, and part of the sequin, it asks actually for 3 different sets of criteria, and that's what's in the pink box at the top. The graphs on the right hand side show our compliance, our achievement for each of those 3 questions. So the blue box explains those graphs. So basically, if you look at the first graph, the criteria there is, are we completing a risk assessment on admission? And by and large, we've broken this down by ward so that we can look at that data in detail by ward and not just as one piece of data. It's pretty much telling us which wards are achieving it and which wards aren't achieving it. The next question then is, for patients who do have a risk, are we actually completing a care plan? So you can see there that we're doing the risk assessment for the majority of our wards, but actually, are we doing care plan or are we documenting the care plan? So our evidence is saying that we're not doing the care plan. You then look at the third set of graphs, that's actually asking, are we actually taking actions of what's on the care plan? So the results that we're actually delivering are much lower because they're looking at the 3 criteria as a whole rather than breaking it down. And this is one of our reflections, is we've been guilty of delivering data for judgment rather than data for improvement. And by breaking breaking your data down, you can start looking at what those problems may be on one ward different to another, and actually start sharing those learnings from one ward to another. So what we're doing as a team, we've actually reached out to our ward managers. We've attended a ward managers meeting and presented this data, and I was really proud with one of my colleagues who'd actually presented this data and then asked the ward managers, how does that feel? Because the nurses and the teams on the ward were not understanding that this data was presenting what it was presenting. So it's about, how does that feel, and how can we support you in looking at what's not working and turn it into what is working. They're the ones who've got the answers, not us. We're not the experts in this, they are. So we've started that engagement. So actually tomorrow, 3 of our team are going to spend some time with one of our wards, and we're actually going to complete a side-by-side audit. So and that's one of the benefits of our team, I think, is because we've still got that clinical effectiveness background and we've kept some of those roles. It's our administrators in the team who do the audit. So they're going to work with the clinicians on the ward as they do the audit and do that side by side to see what those challenges are. We're going to look at the data. So one of our analysts is actually going to speak with the ward managers and the team so that they can understand what the data is telling them and engage in that conversation. Our facilitator is going to be managing that conversation so that we can start looking at what those barriers are and thinking about what the root cause to the problems are, and then we can start looking at what the potential solutions are and talking that through with the clinicians. And then as we do this on each ward, we can actually share the learnings from one ward to another and take the findings back to the ward managers meeting. So this is just an example of where we need to do something. It's a requirement for our CQIM, but how we're working as a team and how we're using our data and engaging with the teams to actually improve patient care. So I'm going to hand you on to Hayley, who's going to talk to you through what she's proud of.
Thanks, Mand. I'm proud of everything, and I think you can see on our slide what we're proud of. It was quite a full slide, so you had to contain us a little bit. So I focused on actually the team itself and really is staying true to that QI principle of share. So I came into the team on a secondment role into the lead post and inherited that we needed to deliver a conference. It was during the pandemic, and actually I'm really proud of the team that actually the team showed a lot of resilience and actually QI to actually switch that from a whole day conference to a 3-morning virtual event. So you've got a bit of a flavour from the slide about what we offered, but it was really great that actually 100 colleagues across a trust during a pandemic took 3 mornings out of their day to reflect, refuel and rejoice, and actually acknowledge that actually the pandemic, whilst it was really hard and I was working through it, with my masks, my gloves, going into, different environments, actually DCHS still did QI, and it was really important that we actually had an event where we celebrated that. And the share piece for me, my secondment reflection was that actually we're an outstanding trust. We do QI, we're just very humble and we're not very good at sharing actually what we're doing. So the springboard of our showcase event was actually, we used a lot of innovation. We used Padlet and MS Teams to offer that as a virtual offer. We recorded it, and now trust members can go on our website and watch it back, and people are engaging. And actually for us, certainly we felt that as a community trust, people have really kind of engaged with virtual and really like that ability to be able to jump on something while they're out and about or across different bases. So the showcase itself was a real success and we got some great feedback, but actually it was a kind of it highlighted that actually as a kind of improvement team, actually we were good at doing communications. We got a lot of creative skills, but we really wanted to have a dedicated role. So Lauren mentioned earlier that actually we kind of had an opportunity within our staffing to try a kind of proof of concept role. So we have now got the communication engagement and project officer role that we're kind of trialing. And I think that's really helped us have a focus on how do we get what is happening out in the trust? How is it shared? How do we ripple out learning? How do we ripple out that energy and enthusiasm and drive for, continuous improvement across, a pretty difficult NHS landscape at the moment. So it's about having events where people have time to pause and celebrate it. It's about having people like Lauren who can make connections and really celebrate what's happening across divisions, individuals, across the trust. And how we're noticing that reach out of the trust is hits on our webpage, impressions on our social media, and views of those videos and the training that we are offering as a virtual offer. And then we've already mentioned, again, how do we share? How do we keep sharing? What are our touch points with our kind of colleagues? We are growing our QI community. It's increasing in numbers. They're engaging with using kind of QI templates that we've put out there, so that actually we've got things, examples, because sometimes people can't work from a blank page. They want to see actually what is realistically achieved within their specific trust that's happening. And we're starting to look at how we can support staff, not just to share within our trust, but actually apply for awards, get funding. And it's really satisfying that we are starting to be involved in projects that are, nominated for HSJ awards, or actually, we've just had a recent one where they've gained a HSJ award. And I think for me, I'm really proud of this. I can give you some examples of where it's hopefully demonstrating that. And then we had our insight visit, which is part of our assurance portfolio within the trust, where execs and non-execs come out to the team and feel it for themselves. And they had a really good quality conversation with the team. And we're getting some of this reflected back, not just from what we're feeling, but actually what is happening across the trust. We also got a really constructive challenge that we are probably a bit too humble ourselves, and that actually we do need to kind of celebrate where sometimes we've sat in the background of a project and we've supported it, and it's maybe not as visible about we were there in the background facilitating the methodology, or facilitating the process to get to the end point. So that again was just constantly thinking, how can we improve within our QI team? I'll hand over to Lauren.
Thank you, Hayley. So I'm just conscious of time, so I'll word through quickly. But this is a project I've been working on, so I won't go into the details of the project, but just sort of how our team were able to contribute to that. So the dementia palliative care team within our trust, the service manager called Gemma, she reached out to our team because she got some funding from NHS England Midlands to create a toolkit so that other trusts can read through this toolkit and implement a gold standard dementia palliative care team within their own trusts. So Gemma didn't really know what to do, how to go about it. She obviously knew what she wanted to put in it because she sort of created this whole team herself. So she came to us to sort of create the actual flip book. So I started on this as soon as I started in this secondment role. So because now our team does have that space for the communication and engagement side of QI, I was able to sort of prioritise this. This has been my number one priority for the past 6 months. And I think because I was given that time from my team to sort of prioritise this, that's why it's gone so successfully. So Gemma had all the content. We liaised with an illustrator who also works within the trust. He was helping us outside of his working hours to do the illustrations and the design of the flip book. So I was liaising with him, making sure he was all right. He had everything he needed. I was also liaising with our main comms team to make sure, because we were very lucky that the actual flipbook is hosted on our webpage. So to make sure the flipbook would actually be embedded in there and all the technical stuff behind that. And then I was also liaising with Gemma, making sure she had all the information she needed. and there's loads and loads, probably hundreds of links within that flip book as well to other documents. So it was a big project to organise. So the fact that Gemma could come to our team and have that space so that she could give these responsibilities to me and our team, so we could take that from her, because she was still working clinically as well as being a manager, as well as running this project. So the fact that she could just give this to us, we'd support her with that, sort of really empowered her and made the project so successful. So it was launched last week. So we'll all step back now, thankfully. I will pop a link in the chat to the actual flipbook if you want to look at it. I know if you're not sort of in the dementia teams, it probably won't be relevant to you, but if you wanted to look at the flipbook as well, because we now do have from this project the funding to create more flipbooks, so it has benefited our team as well, so that we can create more engaging things for staff as well. But yeah, so this was our little project, and that's sort of what we're really proud of, and the fact that we could support these clinical staff with these bigger projects as well.
Thanks, Lauren. And as one of Lauren's leads, I'm very proud, and I know Hayley is too, of the work that Lauren's done on that. We're just going to quickly run through some of our barriers. We're not going to go through all of these, and we were reflecting just this morning on what our barriers and what these are still our barriers. We've actually put what we have faced here. We do still face these, and there's actually they all sort of interconnect with one another. Is our data reaching the right people? Are we still doing that? Or we've always done it this way, and we get this in our own team just as much as we do outside of that team, and they're probably challenges that you guys are seeing yourselves, but actually, how do we change that culture, and how do we change that so what? Just because we did it like that last time, it doesn't mean to say we need to do it that way next time. So there is still an expectation that there's that measurement for judgment, and actually for me, that resistance to move away from how it's always done. So they were my sort of key barriers. Was there anything that you wanted to say on these, Hayley?
I think again for us, what we've been challenged on is that balance between we still have a portfolio of that audit work and the QI, but we've actually tried to see an opportunity to actually let's make clinical audit staff actually want to engage with it, because they can actually see it leads to on the ground changes that will benefit them and their patients.
Thanks for that, Hayley. So moving on then to our top tips, and when we were actually again preparing for this, we can't actually say that any one of these top tips are more important than the other, purely because it depends what project you're on and what situation that you're in. So these are just what we've taken away. All three of us have pulled these together. Again, I'm not going to explain any of them, but sort of talk through them. So whether you want to ask any questions, because we're just shortly about to finish the presentation on any of this, we'd be happy to answer any more questions on those. So I think I'm handing over to Lauren now, just to close the session.
Yes, I just want to say thank you, Andrea and Jess, for having us today. It's been really great to sort of see everyone here and share our story. I think it was really empowering for us, the fact that we have had to sort of squeeze it all into this time, and we just had so much we wanted to talk about. It was hard just pinning down the things we wanted to. So you can see on there we've got our internet page with all sorts of projects that staff have done, our Learn at Lunch videos, training videos, all sorts of stuff we do. You can scan that QR code, and like we say, we have got the QR community. At the minute it's predominantly internal, but we're more than happy to sort of have external people come as well. And if you have something similar, like where your QI people meet, I'm more than happy to come and attend, see how you do things, and sort of network in that way as well. So please do get in touch if you want to, and thank you ever so much.
That's absolutely wonderful. Can you hear me now? Yeah, fantastic. So thank you, Hayley, Amanda and Lauren. That was an absolutely fantastic presentation. We do have time for a couple of questions. Has anybody got a question that they would particularly like to ask in the last few minutes? We've got time for probably one or two. I do have one that came in earlier. Anybody want to put their hand up? This is your opportunity to engage in the conversation. Sarah, first hand up.
Thanks, Andrea. Thank you for that excellent presentation. There's loads of food for thought in there, just so much. So it's probably take me a while to digest it all. But one of the thoughts that's at the top of my mind is to do with the more successful you get as a QI team and spreading that culture, the more requests you get for people wanting to engage with you, wanting support, more requests for projects and things like that. And I think it's a bit of a stroke of genius that you've linked clinical effectiveness and improvement together so well. I'm really inspired by that. But how do you cope with all the competing priorities? It's really interesting what Lauren said about how said about how you enabled her to prioritise that really important work on the flip book with the dementia palliative care team. So how do you make those decisions on what you're going to focus on at any current moment in time?
I'll step in there if you don't mind,
Thanks.
Hayley. It's a really good question, Sarah, so thank you for the question. We're trying to approach QI not from us, we're the ones who do it, more from a coaching and supporting. So we've spoken about the QSA qualification and courses that we've done. We're actually working with Joined Up Care Derbyshire to actually train our colleagues throughout Derbyshire on that, and we're actually encouraging colleagues from all across our trust to actually attend that training, so that we're empowering them and giving them the skills and the tools. So and we're doing that not just through that training, but when we support with projects. So when we set out with a particular project, we make it clear that we're not the people who are running this project, it's the teams who are running it, but we're there to support them so that next time they want to do something, they've built those skills and that knowledge to do that. So that's a focus for us as an approach. But the second part of it is actually part of our current challenge at the moment. Is we've got fantastic people in the trust who have got great ideas, and we're calling them, we're pushing at those open doors, because they're the people who are engaged and have got that desire to do that. But then Hayley and I as leads are looking at actually what's the strategy and where does that fit into that board assurance framework, and actually that's that battle against our capacity. So for example, we've had a recent patient questionnaire go out which has had 1,300 responses. That's absolutely fantastic, and there's some qualitative analysis in there. But actually when we look at the division and the strategy, the quality lead is saying our clinicians are too busy to do something with this. So how do we balance our capacity in supporting that open door with somebody who's got a great idea in that project, but also how does that fit into that framework and that strategy for the division for us from a capacity? And that is just a battle that we don't know the answer to. I don't think we ever will, but it's just about managing that at the moment. And I think that's Hayley and I are actually only just 6-7 months into the job share, so that's where we're trying to focus our support in the team, but also supporting what we deliver to the trust as well.
And I think we've been lucky enough to actually be able to get a kind of reps into the organisational strategy working groups. And what we've actually done with that is sent Lauren, because Lauren can come with that drop the jargon QI principle. She can come as like a local Derbyshire person who is maybe receiving care from our trust. And also something that's on our kind of horizon for QI is about health inequalities and health literacy. So she's also there to hold them to account to that as well. So actually, if we can get QI in at the strategy, we're coming from both ends. We're trying to come up from the grassroots of connecting just one person with a good idea, but actually we're trying to get the organisation to have that golden thread of QI so that people are seeing it through the strategy. So again, it all aligns.